Hi, guys. Welcome to the Lunge and Lift podcast. Today, we're joined by a very special guest, Dr. Jon Houghton. Jon is a sports doctor who's just returned from the Euros as the Chief Medical Officer for the Wales football team. He's also worked in cricket, or works in cricket, and in ballet, and works at Fortius Clinic in London, where he treats all sorts of sports injuries, specialising in tendon and bone injuries. This is a really great episode that Rob and I thoroughly enjoyed. We go deep on professional sports, the differences between treating elite athletes and everyday athletes. A little bit of morality in there around how to decide what the best course of action is, and a little bit of insight behind the scenes in professional sports, as well as some practical takeaways on how to manage your own injuries. And we both learned a lot about the detailed nuances of working with tendon injuries, which are increasingly common these days as people tend to train so much harder. But before we get into it, a big thank you to our sponsor, Wit Fitness. Please check out the store in One New Change St Paul's and the website at www.wit-fitness.com and use discount code LL15 to get 15% off your purchase. All right, let's get into it. Jon, welcome to the show. How are you doing? You're just finishing up your quarantine.
Yes, yeah, I've just had my test to release. Just had about 5 or 6 weeks in the Wales bubble. No, I'm sort of readjusting to life in the UK, which is a little bit weird, but it's good. It's good.
Glad to hear it. And we're going to dig into the Euros a little bit later on. But first, for our listeners who might not know who you are, please could you just give a quick intro and who you are, what you do for a living, and we'll go from there.
Of course. Yeah, I'm Jon Houghton. I'm a consultant in sports medicine and rheumatology. So I've got lots of different hats with work, which is a fantastic pleasure and an honour, really. So I spend most of my time at Fortius Clinic in London, which is a collection of orthopaedic, sports doctors, pain doctors across 3 sites. So that's my kind of day job. I'm also the Chief Medical Officer for the Wales football team. So I've been doing that job, working with Wales for just over a decade, being their CMO for about 7 years now. I'm the CMO for Surrey County Cricket at the Oval, and up until fairly recently had a consultancy at the Royal Ballet. So lots of different hats.
Nice.
Yeah,
that's awesome. And how did you get into sports medicine?
Yeah, that's an interesting question. I love sport. If I could have been a professional footballer, playing Division Two, earning just above average, I'd have taken above medicine every day of the week 30 years ago. So that was always the dream, and the dream's not yet dead. I'm pushing 50, but I think I have to give up on it now. I ended up sort of being all right at science and maths, and I think I'm from an era where when you went for a chat about your careers officer, it was kind of fireman, astronaut, doctor, baker, that sort of thing. There just weren't the jobs out there. So because I was good at maths and science, I got pushed down the sort of medicine route and decided very early that I wanted to be a doctor with absolutely no idea what it involved at all. But I had an amazing time studying. It was 6 years of hard graft at uni, but I was playing sport kind of 6 days a week alongside my studies. So football was a big part of my life back then. So I guess I was always looking to try and merge those two loves together of having a job that would involve sport, but I wasn't really good enough quite to be a pro, so I had to get into it some other way. So I guess I ended up training in something called rheumatology, which is mainly sort of dealing with joints, bones, that sort of thing, arthritis. And the idea was during my training to become a consultant, I did a number of additional qualifications, additional degrees in sports medicine, learning how to do musculoskeletal ultrasound, doing specialist sports clinics. And so I kind of was always pushing towards that route, and then became a consultant at the tender age of 34, I think it was. And I was quite fortunate at that time. I was looking really to use my skills in injury and sports and rehabilitation. And unfortunately, the NHS is quite limited in its budget for that sort of thing. But I got offered a job to go and work with the military at a place called Headley Court. So just outside Epsom, and I'm sure a few of your listeners will have heard of it.
Yeah.
It was, we were pretty much on the map during the Afghan conflict. So I joined Headley Court, must have been about 2006. So it was just towards the end of the Iraq conflict, early Afghanistan. And Headley Court was basically a sort of tertiary referral centre for injured servicemen and women. So we had a whole bunch of musculoskeletal injury rehab, so people who'd had specific fractures, ligament injuries, surgery, who weren't doing so well, who needed a bit of additional inpatient care. And then we kind of looked after all of the trauma from whatever conflict was going on around the world. And at first that was not very much, but I was kind of there through the 7-8 years of the majority of the Afghanistan conflict. So we went from not doing very much trauma to huge amount of trauma. Just as an example, we used to have an inpatient ward for servicemen and women who needed inpatient care. And it was 24 beds when I got there. And 20 beds were for neurological problems, so normally brain injury. So people had had motorcycle accidents, parachute accidents, that sort of stuff. And then 4 beds for what we call complex trauma. And by the time that I left, we had 150 beds for complex trauma, which was servicing those people who got serious injuries through the Afghan conflict. So, massive change in
you must have seen some things then. You must have seen some serious injuries coming back.
Yeah, no, it was it was a really interesting time. I mean, I guess in the history of medicine, progress normally comes around bad things. It's we've learned a lot about how to manage things because of COVID, and within that conflict, the sort of both the emergency care of people and the care of amputees, the knowledge just became huge, and there are various scores which I won't go into, but if you get knocked over by a car outside on the street, then there's a specific trauma score that basically says how severe is it? Is it a mild trauma, moderate, or is it are you going to die from that trauma? And the quality of emergency care out in Afghanistan and the resources and the expertise that we had out there meant that we were suddenly having 20, 30, 50, 100 patients who'd had an injury who on this score should have been dead. So they were being kept alive because of the expertise and the facilities. And so then you've got to work out how the hell do you take that individual and give them a life back. So, and I learned a huge amount then about trauma and rehabilitation and psychology of injury and all of those other things. And it sounds awful, but actually, there was some horrific injuries, but absolutely some really uplifting stories. And the way that the majority of the servicemen and women dealt with life-changing injuries was just absolutely humbling. And you can still see that today in all the work with Health for Heroes, the Olympic Games, and the number of military athletes that have come through that. So they're definitely a slightly different breed, and they approach things very differently to the man in the street often, which is why so many of them did so well, I think, in the long term. But that's we probably got a little bit diverted, but
I love it because you've gone so far that way, and I'm now intrigued. How on earth you're now in football. So that's how's that happened?
Yeah. From people with really severe injuries to those
people pretending they hurt themselves on the football pitch. I mean,
great. You go down if they have a slight flick of the chin. So I guess I was using my sports knowledge and expertise within some of that injury rehabilitation, and so we used to take a load of our military doctors and physios and put them through a sports medicine master's course at Cardiff Met Uni. Because of my skills, I got invited to go and examine and lecture on that course. So that was part of my job role within the Army, is taking through those junior docs and Army physios and training them up in sports medicine. The guy who was sort of running the course, setting the course at the time, was the Chief Medical Officer of the Wales Football Club. So I was going down to Cardiff on a regular basis. We got to know each other. He was a great mentor of mine, Mark Ridgewell. And so he kind of got me involved when he was covering the Welsh team at the Commonwealth Games in 2010, I think it was. So he was away with the team, so I covered the Wales team for a couple of camps, and sports are funny. It's a funny world, and I think my love of football, my knowledge of football, and just my personality, I was able to fit into that environment and use my skills without coming across as too scientific or too boring or too nerdy, I guess. So things worked out well from there, and so I started getting more and more involved through that way. And one thing leads to another, really, and I was always looking for the next experience of where do you go to learn more, get a different sport experience, and to push yourself a little. So it's kind of evolved over the last decade, really, with my training, then the military, then Wales, and working in private practice obviously gives me a huge amount of exposure to lots and lots of different injuries, which is kind of my bread and butter and what I love doing day to day.
Great. And what exactly is your role as a CMO? Like, what does that entail if you go on a tournament camp?
So it can vary as a CMO depending on what the organisation is, and I've got a few colleagues who will, maybe, for example, be a CMO of the Lawn Tennis Association, and so they have a much more of a day-to-day, week-to-week role. Whereas with international football, all of our players are owned by other clubs. So, there is no need for medical care from me during that period. So I kind of work with the administrators at the FAW and the head of the medical services. So we'll be planning for a tournament. And then on the whole, the role is mainly whenever there's an international break. So if you're into your football, you know that there's that 10-day break where your team's not playing and everybody around the world, set by FIFA, disappears off to their nation. And so for that whole period, we'll have a camp of maybe 26 players in the squad. We have about 20 staff, and I'll run the medical team for that period of 10 days. So, first job is kind of turn up, check them in, make sure they've played normally on the Saturday or the Sunday, look at what injuries they have, if they're presenting with any injuries, making sure we've got a clean bill of health. And then throughout that 10 days, I'm kind of almost GP to the squad. So coughs and colds and diarrhea and all that good stuff, which is probably the part of the job that I like the least. But then, each day we'll train, and I'll cover the pitch side emergency care for the training. And then there'll be a kind of clinic in the afternoon, see any issues from training, monitor any injuries, helping coordinate scans, any other specialist opinions. And ultimately our job is to keep those 26 players fit so that the manager and the coaching staff have got 100% to pick from when it comes to game day.
Great. Do you have any accountability to the clubs, given football's so club-centric? Are they breathing down your neck when you're handling somebody who's got a bit of a knock or an injury?
It all depends on the club a little bit. And I think one of the other things that I've learned over the years is that it's important to build a relationship with the medical staff at those clubs. So, you know, knowing them to talk to, being able to phone them up, have a conversation with them, and you have to sort of gain their respect over a period of time. And if you develop that relationship, especially with the bigger clubs, then that kind of pays dividends. And, you know, certainly there'll be times when a club doctor will phone me up and say, look, we really don't think that X should be involved in this camp. And, you know, England used to have a policy of, regardless what the club says, they have to turn up, and FIFA says this, they have to turn up if they're selected and be assessed by the medical team of that nation, who then will make a decision in conjunction with the club. But I think fairly early on, we'd have a sensible conversation, and often we'd say, look, it's not even worth them coming. And that would gain you a few brownie points a little bit later down the line when you perhaps needed to be a little bit more gung-ho with a player and say, well, look, we're going to try and get them through this, and get the club on side with that. But ultimately, yeah, they're paid by the club. But we're covered by our own indemnity. So, you know, if I mess up, I've got cover up to about 70 million.
Doesn't go that far these days.
Yeah, that should go. And in fact, you know, it used to be 20 million, and then Gareth Bale got bought by Real Madrid. So obviously, you know, he was suddenly an 80 million pound player. So we had to up the policy. So, you know, if we do mess up hugely, then, or actually, if the player gets injured while they're playing for us, for example, then there is a specific insurance policy that's, you know, each country pays and backed by FIFA, so that they will pay for their care and loss of wages, etc., back to the club if they're injured on international duty. So there is a little bit of payback.
It must be mental, because it's like, as the years are progressing, the amount of money players are going for nowadays is insane. And obviously, I remember when Bale first obviously went, and like they said, like 80 million. I was like, man, wow, that's so much money. You know, world class player. That's insane. Now you got people going left, right, and centre for it's just astronomical amounts, and you're just like, does that pressure ever kind of get to you in any way? Like, does that, because then when you think, like, say Bale, when you say worth, say 80 million, do you think, like, do my decisions, like, how does that play out? Like, is it any different compared to, say, some of the other players, or do you have to treat them differently even though you shouldn't? Like, how do you feel there?
I think you've always got it in the back of your mind, and you know, I think people are lying if they say it wasn't. You know, there are so many decision modifiers working in sports, because, you know, if Joe Public gets a specific one particular injury, you might treat it with X. If you've got an international footballer or an international cricketer who gets the same injury, you might treat it very, very differently, and that's because of certain things. You know, that's their job. You know, when's the next game? How important is that competition for them? And there's so many variables around that. So, yeah, of course, when you've got players who are much, much more valuable, it's sort of at the back of your mind, and I guess it's more, you know, your decisions and what your actions will be played out in a public forum, which for most medical things, you know, confidentiality is the key. But these days, everything gets out and everything's very public. So, you know, if you do something on the pitch, there'll be people on Twitter at the end of the game giving you the thumbs up or the thumbs down for how you've managed a particular injury. So I think most of the time I can put that to the side, but you do reflect on it a little bit as part of the slower decision making.
Yeah, you touched on something really interesting there. I think handling competitive athletes differently from your Joe Blogs is something that I think, working with more competitive athletes myself, that I wrestle with a little bit, because their competitive performance is so important to them. What sort of, do you have any frameworks, or what sort of considerations are you making for where to draw the line between we're going to optimize for your short-term performance versus your long-term health. Because if you've got a really expensive football player whose club have paid a lot of money for them and they want to squeeze out their value to play, how do you trade that off against a decision that might impact their long-term quality of life? Is a very difficult place to be, I think, as a medical professional in that interaction.
Yeah, no, I think you're absolutely right, and I do think that in a lot of elite sport, then that is abused, and there are certainly a lot of other countries that have specific training programs where medical care is not the priority, and they have a large population, and it's an attritional thing. So the ones that end up at the Olympics or in the national team are the ones that have survived through the injuries. There's no doubt that there is a risk of being an elite athlete of poor decisions being made. I think a lot of the way medicine has moved in the last 10 to 20 years has all been about giving patients much more information and allowing them to make a lot of the decisions themselves. And it's an interesting concept, because a lot of the older generation, you go through this whole thing and say, well, we could do X, Y, Z, or go back to A, but ultimately this is the information and it's your choice. And they just look at you and just say, you're the doctor, you're supposed to tell me exactly what to do. So they're expecting to just say, this is what we're doing. Whereas, a 20, 25-year-old, you might give them 5 options and they want 7 maybe. So, I think that's a mindset thing. And certainly within elite sport, if you are making sure that your player understands the risks and the benefits of a certain intervention or pushing them through a specific injury, if they're fully on board with that, then I can kind of sleep at night a little bit easier. It's been a massive question over the years, and I think talking more and more with elite sports people, they are built a certain way and they have a certain mentality, and you guys will see that also. And a lot of them have short careers, and even with football, it's a relatively short career, even if you're one of the big top earners. But sports like rugby, for example, even shorter. So that individual has a skill that earns them money. That's their living. It pays for their mortgage, pays for their family, and for them, that might be more important than whether they need a knee replacement at the age of 40, or whether they, play golf pain-free when they're 55 years old. So it's all about trying to protect people as much as possible. And certainly if I think that things are really just insane, then I would say that, and I would always say that. But it's a lot of my job is really risk management, working in elite, kind of, because nobody's ever 100% fit, and all footballers will tell you this. They will never get up in the morning, stretch, have no pain, and feel great and ready to train. And I think across the board, that's the case for a lot of elite athletes. So you're constantly managing what is the risk of pushing them through this training session, match, intervention, against, am I doing them really bad long-term damage?
Yeah. And how does that contrast with sort of more recreational athletes who take their training very seriously, but it's not their profession? Because sometimes they're nearly as dedicated as the elite/professional. And does your advice differ for them in those situations to say, like, it's a difficult message to deliver, right? If somebody loves their training.
Yeah, it is. And I think that I definitely will make different decisions a lot of the time. Often it's more about the time. The time pathway, because I deal primarily with a lot of overuse injuries, and in elite sport there's a little bit more of an acute injury thing. So you've got a time period where your manager or that player needs to get back on the pitch. So I think with the non-elite athlete who's pretty serious, then I might use the same treatments, but just maybe extend the time periods that you're expecting them to get back to a full recovery, so that you're not constantly trying to push them into a place where they might break down again and do further damage. So that's one thing. And I think the other thing is that with most of the really serious non-professional athletes that I work with, your people who just love their exercise, is primarily a mental health thing. That is such a, that is their being, their identity. And if you take that away from them, their life is much more miserable, and their mental health is significantly affected. And so I guess, you're still trying to juggle what's the best for that particular individual. But I guess one of the things about being a sports doctor is a lot of doctors will say, well, if it hurts when you play five-a-side, just stop playing five-a-side. The first thing that I'm trying to do is, what's your love? What's your sport? How can I get you back to that? So that's my starting point. And, you clearly can't always achieve that. That's unrealistic. But if you start off at that point, then you can adapt as time goes on and allow that person to go through the journey of maybe having to stop a particular sport that they love or a particular aspect of that sport. And they often then, if they're dedicated enough and they're crazy enough to love their sport so much, they find a way around that or into a different area of the sport or a slightly different sport, for example.
What is it, do you think, that's given you that mindset? Because I've had a very similar experience with medical professionals in the past, where they say I've had a shoulder injury and they just say, oh, just stop lifting weights, just do cardio instead, or stop playing rugby when I was a teenager. And if you are a person who loves their training or loves their sport, that's just not an option, especially if you're still quite young. I think it's just like, I'm not that broken that I can't do this for the rest of my life. Like, I can't, as a teenager, the idea of not lifting weights for the rest of my life when I was just getting into gym was just madness for a little shoulder ding.
Yeah.
And why is that attitude not more pervasive in the medical industry? Is it just a cop-out that the doctors think, I can solve this problem by never putting stress on that shoulder again, in that example, versus actually trying to get them back to a much greater quality of life in terms of the things that they're able to do with their body? It's a bit of a jumbled question.
Yeah, I think I get where you're coming from. I think it's the easy way out is to just say stop weightlifting or stop X, and I think that comes from, I don't want to say a lack of expertise in a bad way. I'm trained as a doctor in a certain field, and if you came to me with a lung problem, I'd be pretty hopeless, and I'd give you bad advice. So, I guess that's why you need that specialization and that education. But I guess I've always, looked at sport or exercise in a very different way to a lot of other health professionals. So, if you look at the scientific literature, if you were going to invent a drug that had fairly minimal side effects, but was super effective at stopping heart attacks, stopping strokes, preventing diabetes, treating depression, stopping cancer, improving recovery rates and survival rates after cancer. If you were going to design that drug that did all of those things, you would be a multi-billionaire. And we've got it already. It's exercise. Exercise does all of those things. So it is the best prescription drug that any doctor can give to any patient. And just reel off the say a medical condition, and you'll find that exercise has some positive benefits for that. And I think that message wasn't taught to me at medical school, and still probably isn't. That is not pushed forward as a public health initiative enough. And so I kind of see my role. Every drug has potential side effects. Even paracetamol. So my job really is to push the drug. So everybody should be on it.
Just a pusher.
Yeah. So I'm a drug dealer.
Yeah.
But my main job as a kind of injury specialist is to just manage the side effects of that drug. And if doctors were to give somebody a medication, they come back a little bit later and they say, oh, well, this gives me a bit of tummy upset, then they might say, well, I'll tell you what, don't just stop the drug. Why don't you change the time that you take it? Or maybe we can give you something else that will stop the tummy aching, or let's change the dose. And I think that's the thing with exercise. What I'm trying to do is manage those side effects so that ultimately they can continue taking the drug of exercise, which has such a myriad of benefits.
Do you feel that you're relatively, say, progressive? Because the way you're talking about like the medical field in general is, I know from personal experience, like you go into a doctor's and you'll know more than a doctor about what you think you have anyway, and then they'll go, oh, it always seems they're always trying to refer out and stuff like that. And it just, when you made that point just there of, if you, rather than just stopping, say, the drug that you've given, you'll work out maybe why it's happening, and then a way to keep taking it as it. And I think that's where, say, the normal GP they just want to just pass the buck continuously, and it just doesn't ever seem to give you that answer that you're after. And it just by hearing all the things that you're saying, do you feel that the exposure that you've had with like the level of athletes and stuff has made you have that different mindset of, actually, no, we want to do, say, X, we want to give this drug to do this, and I now need to make sure that this works for this person? As it because of your exposure, or is it just...
I think a lot of it's, if I'm honest, it's personality. I'm a people pleaser. And so if someone comes and says, I want to play tennis and my elbow hurts, and I can say, oh, I can make you play tennis again, then they'll like me. But that's probably back on the psychiatrist. But no, there's an aspect of personality there. I think, I don't want to give GPs a hard time because they have a really tough job. And, but when I meet a patient for the first time, I've got 40 minutes. That's a standard consultation in an elite sport. I get even longer. GPs might have 6, 8 and they've got patients with multiple pathologies, lots of drugs, so they have a tough time of it. But also, like I said, it's a question of training and education, and it is getting better. I think more GPs are understanding the role of exercise in keeping people healthy and helping their problems. And you kind of say, well, they want to refer on, but often, if it's outside of somebody's scope, then it's the right thing to refer you on. But I guess it's a question of making sure that you then find the right person, because there's still, I work with some fantastic orthopedic surgeons, and they are working at the absolute top of their game, operating on elite athletes. So they get it, but they've self-selected into that field. There are other orthopedic surgeons who will be the doctor who says, no, just give up, stop, because that's easier for them. Again, that's a lack of expertise within that particular area. But for me, it's understanding what does the patient want out of the consultation? What's their goals? What are their concerns? And that might be very different from amongst all the patients that I might see.
So, just kind of leading on from the progressiveness of how you come across as well, is, have you seen the massive shift within the training world, and say like the utilization of, say, weightlifting and strength and conditioning within, say, football? So have you seen more clubs, and especially obviously, say, Wales, have you seen them integrate, say, some classic strength and conditioning drills, different technologies and stuff like? How does it work, like, behind the scenes of like professional football?
Yeah, there has definitely been a big shift. and that's been relatively recently, I would say. So, I'm not going to go into names, but the first couple of camps that I did with Wales, it was pretty standard. After dinner, and we'd do an evening clinic, we'd wrap up, and then you were kind of expected in the bar, and all the staff would sit there, and you'd have beers till kind of 2 o'clock in the morning, and it was great fun. It was very social, and the players would kind of go off into town and do their own thing, and they'd do the same. And the next morning you all got up with a bit of a hangover. A lot of the pros the same, and then you did what you did. And football is or was a working man's game, probably still is. And so you take on those social constructs. It's footballers were never always the fittest. Pre-season was always dreaded because they'd spend 4 to 6 weeks of just eating and drinking what they wanted to, and then they continued doing some of that through the season. And certainly in England, we had a big problem with that. And in Europe, it was a slightly different game, and it took, I think, other countries' approaches to football to influence what happened in England and Britain, and that was very much part of the Premier League. When we started attracting these overseas players who were looking at their British colleagues saying, what's going on here? What are you doing? Drinking more than a pint, sort of thing. They just couldn't understand it. And I think that started to change things. And certainly I was working with Wales when Gary Speed was the manager, and I think he was one of the first people to really get it. And unfortunately he's not with us now, but in the short period of time that he was involved, it was pretty much dry camp. This is what you're here to do. This is a job here that we need to do, and we need to take it seriously, and this is how we're going to do it. And the nutrition ramped up, the training periodization changed, and we suddenly started to see how all of the science that can improve performance started to seep through. And that's kind of carried on significantly with the Wales national team. And I think more and more top clubs now will utilise science, periodization specifically of training, and technology to try and get the best performance out. And those old school players, there's still a few of them around, but it's not as common now. And most of the youngsters in the Wales squad just want to play on their PlayStations. To be honest, they're all pretty good at it, but that's the new drug of choice.
Yeah. I heard once that Harry Redknapp never let anyone put a weight overhead, not that they really need to for football, or train hamstrings. Apparently, it just was like, you don't train hamstrings, that's how you pull hamstrings. So any exercise that was involving hamstrings was just absolutely not allowed, which I thought was quite funny.
And there are definitely still managers who that's their belief, or to a certain degree, they will see strength and conditioning as harmful or getting in the way somehow of that individual's performance.
Yeah, only if it's done wrong, I think, would be my synopsis of that. Cool. So we talked a lot about the football. I want to learn a little bit more about your expert area of tendon and bone injuries. Why did you choose that? And then, let's go from there. I'll let you answer that one first.
Yeah, so I guess, again, it's one of the areas that a lot of sports doctors specialise in. So a sports doctor is not a surgeon. So we've got our orthopedic surgeons that we work very closely with, who do most of the operations on muscles, bones, tendons, ligaments. So a sports doctor is not a surgeon, so we're physicians. So we primarily use non-surgical techniques to get our results. And I guess for me, I've always been a little bit more interested in things like, why has this happened now? I like the story. I like trying to work it out. So, if somebody is sprinting, pulls a hamstring, then, or they get tackled, let's say, and they get a ligament injury from that tackle, you can say, well, clearly that injury's come from the tackle. For me, I'm trying to work out, why has the athlete developed this problem now? And so I've kind of moved into specialising in more of the chronic overuse injuries, or the complex injuries that haven't got better. And we know that around 30% of musculoskeletal injuries are tendinopathy, and it tends to be that chronic overload type picture, even to the extent that most people with tendon pain will have trained through it for a significant period of time. Some people, a few weeks, others a couple of years before it stops them from actually doing the task that they want to do. And similarly, bone stress injuries are that sort of chronic type overload injury. So those are the ones that make me have to think about not just what's the best way of getting this better, but why did it happen, and what can I do to prevent it happening again?
Yeah. And on that sort of overuse side of things, do you find that it's, well, I guess everything to some extent you could describe as a sudden spike in volume? Is that how you think about it? It's just, it's too much too soon, essentially, in some way, shape or form.
Yeah, I mean, it's not always just that. Everyone thinks sudden spike in exercise, as in suddenly taking up a new sport and I'm down in, or a new thing in the gym and I'm doing it 5 times a week, and then 2 weeks later I get my tendon pain. It can often be really, really subtle, and it might just be that they've changed the pace of their run, for example, or they're going on a different route and suddenly they're running uphill or on a slight camber or on a slightly different surface. So there can be some really subtle differences, and certainly in terms of bone stress and tendon injuries, COVID has played havoc, mainly because the professional and the amateur sport, you've got professional footballers or professional sportsmen who have a set pattern over the year, which is pretty much the same. They have the season, off-season, pre-season, and so their body adapts to that. And then suddenly, if you stick their off-season in the middle of their season and then put a pre-season in the middle of a season again, then things start to break down pretty rapidly. And I run a specialist tendon clinic, and we saw probably 20, 30 elite international level partial tendon tears, which just a massive spike in that particular one injury after everything started coming back in September, so between September and now. So I think that those changes are huge, and COVID was a massive part of that. It just stopped people doing what they'd normally do, and they had to adapt, and then you're much more prone to injury.
Okay, so what sort of practical advice might you give some of our listeners for avoiding or managing a tendonitis injury?
Yeah, so I think, like I said, for the vast majority of people who develop tendon pain, it's been there in the background for a while. So I don't know whether you guys have had personal experience of that, but often you'll have symptoms that you can manage for a period of time. And that's the kind of early warning sign. And unfortunately, it's often not bad enough to stop you doing what you should be doing. So you kind of, some people will take the foot off the brake, others will just push on through it. And then once you've had that pain for about 2-3 months, we know that the nervous system and that chronic pain side of things starts to creep in, which can be a real problem also. I think what I would say to people is that in the early stages, just a very simple reduction in activity can solve the problem. So, if you're getting a particular tendon pain on a specific activity that you're doing 3 times a week, maybe just drop the volume by 50%. Volume, intensity by around that sort of time, just for a week or two, just to see if things settle. And often that's enough just to buy the tendon enough time to recover. And we know that it's that sort of chronic, that chronic repetitive load where you don't give the tendon enough time to repair and catch up. So that's the basic principle. I think that if you get a really bad acute tendon, then there are certain medications that we often use with our athletes. And there's some good evidence that using a short course of anti-inflammatory medicines, something like ibuprofen, 400 milligrams, a couple of times a day for maybe 2-3 weeks. In addition, there's some good evidence that things like omega-3s are really good for tendon repair and tendon turnover, as an anti-inflammatory. And then in our elite athletes, we use a specific antibiotic called doxycycline, which also has that anti-inflammatory property as well. So I would have no problem saying to any of your listeners, if you're getting a little bit of tendon pain, cut the volume, cut the intensity, couple of weeks of anti-inflammatories, start some omega-3s and see where you go with things. And really, it's that consecutive days of exercise which is really bad for tendons. So most of our rehab programs are based on at least a day off in between to allow stimulus to the tendon cell, biological response, repair, then you stimulate again. If you're stimulating a tendon every day, it's too much. And so even dropping to alternate days on a specific activity might be enough to just give that tendon a bit of time to recover. So that's the basic advice that I think you can have for any tendinopathy in the early 2, 3, 4 weeks.
And once it goes beyond that, which it quite often does for people, what needs to happen? They need to come and see you? Is that...
Yeah, so it all depends. I realise that access to healthcare is very, very different amongst various people. And we work in the City of London, where there's a lot of people who either can afford to pay or are well insured. So I think that pathway is a lot easier. I think that a good physiotherapist is an excellent place to start. And if you get somebody who's used to dealing with tendons, then they're able to put you on an appropriate sort of rehabilitation program. They will look at what exercises you're doing, try and take out those ones that are irritating. And again, one of the common mistakes that people make is they just stop everything. So tendon cells will only repair and regenerate with load. So if you rest a tendon, it won't get better. You can sit there for 3 months, it won't hurt as much, but then when you start that activity again, it will hurt again because it's not gone through a repair process. So there has to be a supervised element of what load you're putting through that tendon to produce a biological healing response so that things will get better and you can get back to your activity. So a good physiotherapist is always a good first place to go for that. And the good physios that I know will work with a personal trainer or an S&C coach, because a lot of people work with their PTs as well, and you don't want the two fighting off each other. You want the two to be working together and talking about what the problem is. I think anybody who's had tendon pain for more than 3 months that is not responding rapidly to any of those things, that's when they should see somebody like myself. And that's where we take a more detailed look at things. We'll often use ultrasound imaging. We know that ultrasound in tendons is as effective as MRI, so it does reduce the cost. It's more dynamic, it's easy, it's there in the office. And so we can make some fairly decent rapid diagnoses and then talk about what are the things that have been done so far, what hasn't been done, what can be done, and look at various interventions that might be helpful for that particular tendon problem.
Great. And I think one of your superpowers is probably being able to interpret the scans and relate it to the sporting movement that's causing the issue. Can you tell us a little bit more about that process and how you might apply those diagnoses to somebody's training program, for example?
Yeah, so I would say that it's a common misconception as well that if you just get an MRI scan, that gives you the answer, and ultimately an MRI scan is just anatomy, and what people don't realise is that it's then a human's interpretation of that picture as to what the problem is. So imaging isn't the answer for everything, so you have to put that all into context. So if I scan a 55-year-old female runner's tendon, I'm expecting it to look very different to a 20-year-old guy's tendon. So the individual patient is very important. I think also expecting on MRI abnormalities, and I have to kind of tell people about this because they get their report and it will have a whole list of things, and they think the world's coming to an end because they've got X, Y, Z. But actually, that's what we see on scans often is aging. It's like if you've got hairs or but a hair loss, we're seeing that in a bone or in a tendon. So you've got to interpret it with that particular patient in front of you. And then I think, in terms of looking at somebody's program, I tend to work on fairly basic rules. So if somebody presented, let's say, with an elbow tendinopathy, then I would say, I'd go through what exercises they're doing or what their gym routine is like, for example, and we'd kind of go, right, does this cause pain or does it not cause pain, or look at the movements that do cause a fair amount of pain. Anything that doesn't cause pain, you just keep that in their program. Otherwise, you've lost them. If you just say, stop going to the gym, then they're not going to come back and see you for advice. So I'm very happy to keep exercises in that are pain-free. And even, I would say, I'm happy to have exercises in that cause pain if they're the right exercises. So it might well be, like I said, most tendons need loading. So if we just kind of take, I don't know, a patella tendon, for example, then what we might be treating that with is a kind of heavy, slow resistance type program. And that might involve weighted squat or hack squat or leg press. And I'll say to patients that while you're doing these exercises, you might get discomfort. And if that's kind of 3 or 4 out of 10, i.e. it's mild on your mild, moderate, severe, and it doesn't feel like bad pain, then that's okay. And then think about the few hours after you've done the exercise and specifically the next morning. So if they get a load of hangover pain and the next morning they're struggling to get down the stairs, that tendon is being loaded too much. But you can have pain of 3, 4, 5 out of 10 on the leg press at the time, 2 hours later, back to pain free, or 1 out of 10. No bad reaction the next morning. That's absolutely fine. The tendon can tolerate that, and so I think you have to educate people about that sort of thing, because they are often have a fear of pain that is causing damage, and that was kind of lesson 1 that I learned, was pain does not equal damage, and vice versa.
Yeah, we've touched on this before, where like ghost injuries and stuff like that, where like I've done my back in, say, deadlifting, and it took a while for me to essentially be comfortable deadlifting again, just because it's whenever I'd go anywhere near a certain load or that might slightly go off pattern compared to normal, my whole body would just be like, no, stop. So it's crazy that the impact of like the mind when it does come to like old injuries and stuff like that. And it's definitely something that we've touched on in previous episodes with like a physio of ours that we know, and also when we have our discussions, and it's such a fascinating thing that is, I guess we're still learning so much about.
Yeah, and like I said, this is why tendons can be really difficult, because they don't respond quickly. They don't repair like muscles do, and you have to kind of get the patient to buy into the fact this might be a 3-6 month job for this tendon to recover. So, and once you get past that kind of golden few months of pain, then the body gets lazy. Our body is designed to operate multiple systems with the least amount of stress and effort that the body needs for that. And nerves get lazy. If you've got a tendon, often what happens is that you get a load of blood vessels that grow in, new blood vessels that grow into that tendon to try and start the healing process. And with each of those little blood vessels comes a tiny little baby nerve. We know that when tendons start breaking down, they start releasing various chemicals, some of which things like glutamate, substance P, which are they're neurotransmitters. They transmit bad signals through nerves. So you've got baby nerve and these chemicals being released in the tendon, and that's what often drives some of that pain. So if you've got that pain there for a few months, that nerve, the default switch is pain. And then you get the secondary association, like you were saying, certain movements or a certain activity, and your body just won't want to take you into that position. And that's part of rehabilitation, is again treating the brain, treating the pain. And there are some interventions that I do, like shockwave therapy, which, over the years I'm not hugely convinced that it necessarily changes the tendon structure, but it's great for nerve pain. And if you can change that nerve pain acutely for that tendon, then patients can confidently load that tendon and load it heavier for a prolonged period of time. And it's, most of the studies on what sort of exercises should you do for tendons, it's very much pointing towards heavy and slow. And so if you get them up to that level, then they're much more likely to get better quicker.
One of my clients in particular, he's got a similar injury that I actually done, and I think he done it at five-a-side, and basically it's in his wrist. And so when I caught a clean once, and it just completely pulled my hand back, and it thankfully didn't break anything, but I had severe pain for 6 to 12 months. It was a good long time. I couldn't fully hold a barbell at all. It was a lot of pain, and for me, it got really bad, and it just suddenly just cleared up. Now, just based on what you were saying there, I was kind of like, I think I got to the point where my body's like, okay, right, you're ready to move on. Now, he's kind of going through a similar thing. So he's just about to turn 60. And is there anything in particular that you might say recommend for someone like that has an injury to an area where there may not be as much blood flow to somewhere, say like an elbow or like a shoulder, something like that? Have you got any advice for that? Or
yeah, I think it's a slightly tricky one, because your thumb is going to be very different to a 60-year-old.
Yeah, no, I know, yeah.
It's one of the the joints down at the base of the thumb, just on the back there, here and here. Those are two of the areas where we commonly see osteoarthritis, which tends to run in families or occupations, etc. So that's going to affect the function of your client, for example. And your injury may well have been something like the ulnar collateral ligament, which is again something that the skiers often get when they bend their thumb backwards on the pole. Those can take a long time to really clean up. But what I would say is I do get a lot of patients who come in, and I offer them, we talk about analgesia, pain relief, and they say, no, I'd rather feel the pain so that I know where I am with it. And I sort of get that, but also I'm a big fan of actually getting the pain down because of that longer term neural influence. So if it's a superficial injury, try the anti-inflammatory gels, try the arnica, try those sort of things in the acute stage, try your supplements if it's more joint based, and try anything that is going to just take the pain down to a much more manageable level, and then do the education about pain not equaling damage. And I guess, for me, I'm in a privileged position because I get all the bells and whistles. I get to see the scans, the MRIs. I can see another MRI a year later, and I can be very confident in ruling out damage, or talk about their fears and expectations around that. But I'm a big fan of managing the pain so that you don't get adverse secondary poor mood, etc., which is probably what you were talking about with your.
Interesting. That's really interesting. Yeah.
That's awesome. And one thing I wanted to ask you about, John, as well, was from your perspective, are there any really common mistakes that typical athletes make, whether they're amateurs or professionals? What sort of things make your skin crawl? Are there certain exercises or practices that have become commonplace that make you wince when you see or hear about them?
I have to be very careful here, Ash, because I know that you're a big fan of lunges, and and I've got a real aversion to them, but that's my problem because I do an ACL on my right knee, so lunges are not my thing.
Yeah.
I think it's more just about people doing things that are not specific or appropriate, and for any person who is going to the gym, they're going there for a particular goal. And I think there needs to be more people, personal trainers, S&C coaches, people who understand about goals and how to achieve that in a gym environment. Because if you just turn up, then you are more liable to injure yourself if you don't know what you're doing. And I think that their goal might be weight loss, and so they need a bit of direction about what's the best combination of cardiovascular and resistance exercise to achieve that goal. They might want to do a bit more bodybuilding, which needs much more specific routine, or they might want to be an Olympic weightlifter, which needs a lot more coaching and a lot more technical skills. So for me, it's more just about people doing the wrong thing for what they're trying to get out of it, and that's an education thing. But I think it needs more professionals that know how to manage that expectation and get people towards their goals. So there's probably not one specific thing, because every individual is very different.
I think that's probably my summary of the state of fitness as well. It's just there's so much randomness and lack of clarity around people, what they're actually trying to achieve in their training, that if they were clear about it to themselves and to their coaches, it's actually a relatively simple problem to solve. But when you're just doing something random every week or every day, and your body doesn't know what it needs to adapt towards, it's quite a tall order.
I don't agree
with lunges, obviously.
Yeah. I have thought of one with tendons. So everybody always gets an injury and they think that stretching will help. So stretching has its role. And I think we're all a lot more aware now that just static stretching has its limitations. But for tendons specifically, the golden rules are tendons don't like being stretched and tendons don't like being squashed when they're painful. And a lot of tendons attach to bone. And so, let's take the hamstring, for example. People get that high hamstring tendon just in their butt crease. We often see this in runners who are kind of 40s, 50s, especially women postmenopausally, because the lack of estrogen is a real risk factor for tendinopathy as well. And they get that tightness, and so they're just trying to stretch it away the whole time. And if you think about the anatomy, as soon as you bring that hip up into flexion, you're both stretching the tendon but also compressing it against the bone and making it turn 90 degrees from its attachment around the leg. So stretching for tendons is probably my nails on the blackboard. I think I've made my feelings about stretching quite clear in the past as well. So John, that's been absolutely phenomenal. I think insightful and informative in equal measure. So thank you very much for your time. We appreciate the chat. Where can people find out more about you, or if they want to talk to you about some specific sports injuries, what's the best way to get in touch? The best way to get in touch is to just look me up on the net. So it's Jon Houghton. I'm at Fortius Clinic in London. If you go to our Fortius Clinic webpage, then my details are on there. I don't know whether, if people want to contact you at the show, I'm more than happy for you to give them my details. And, I tend to offer most of my patients a pretty personal touch. So, they'll have my personal email if they need it. So I'm more than happy for people to drop me questions and just say, I've got this, and I can try and advise them or say, look, I really need to see you. So that's always a pleasure.
We'll put that information in the comment box down below for anyone that does want to get in contact.
Fantastic.
What an episode that was. Thank you very much, John, again for coming on. We really appreciate all those insightful knowledge bombs there. But as always, thanks again for your time, for giving us your ears for this podcast. Please do share with someone you think may enjoy and get something from this episode. As always, you can subscribe to us on YouTube, Apple and Spotify. And if you are feeling generous, a cheeky Apple rating and review will make our day. And if you do have any questions or you do want to get in contact with Jon, all the information is in the comment box down below. And if you want to get in contact with us, you can either slide onto our DMs on Instagram at lunge.lift or email us at contact@lungeandlift.com. But as always, thanks again, and we'll see you next week.
Cheers, guys.